to the first committee meeting of 2026. Thank you all for coming. We really appreciate your time. Since this is the first committee meeting, just a couple of things. We do have a new mic here. If somebody that's not at the table needs to speak, if you can go up to the mic, speak directly into it. We appreciate it for everybody that's back at home. Personally, how Health and Human Services will be doing it is we'll go through all the agenda items, and then if there are legislators that are here that have questions, we will reach out to them. And if departments need to leave after they present, just let me know, because then I'll have them ask you questions before you leave. Because we'll let the committee get through everything, and then we'll allow other legislators to come into it. Besides that, we can get right into it. I will call the first meeting of Health and Human Services for 2026 on January 20th, and the time is 8:46 to order. Our first order of business is to approve the meeting minutes from the December 10th committee meeting. Are there any corrections to the minutes? Seeing none, the minutes are approved. And today we have some guests with us. We have Kelly Varamogiannis, thank you, and Commissioner Cunningham, thank you for joining us, from Child and Family Services. Wanted them to come in, kind of give a brief overview of what's going on in their department, and give us an understanding of the work that they do and anything that they think that we should know. So thank you for being here.
Sure. Thank you for having us. So good morning. I'm just going to start with a little bit of a high-level introduction and then hand it over to Kelly. So child welfare is one of 5 divisions within the department. Obviously, it's the largest with a huge main focus on the safety of children. Child welfare also, one of the big shifts over the last 50 years or so was to keep kids at home and prevention. So yes, safety primary issue, and then we do whatever we can to prevent removing children from their homes. And when we do have to remove children, we try to really work hard to ensure that they stay with other family members. And we've done a lot of work. The division has over the last 10 to 20 years on that piece. And then if we do have to remove children and place them outside of families, reunification is the #1 goal. That's really what the whole team strives for. The other divisions are mental health, juvenile justice, youth development, and our school-based team. And we do a lot of cross work, as you can imagine, families across a lot of those different divisions. So Kelly works with our other deputies and directors to really serve kids and families in the best way possible. So over the past year or so, some of the initiatives that Kelly will get into more detail, we have established a school-based team of investigators. So there's a unit of investigators that are officially dedicated to all Syracuse City school districts, and all SCR reports go to that team. So the number of reports received and accepted by the SCR in 2025 was down a bit. We contribute some of that to this work of the school-based team, really helping the schools understand when to call in a report, when other resources are available, and then also using Kelly's staff as resources to help talk through situations and whether or not they need to call in a report. So that has really been beneficial, and Kelly has done a lot of community education so folks really understand or get a better understanding of the system and what can be done before or without calling in a report. And think that's really helped the community understand the child welfare system and what's available out there. Our staffing, we have 153 funded caseworker positions. We currently have 15 vacancies. Also should note that I'd say probably 80% of our staff is fairly new. I refer to it as post-COVID hires. It's a very difficult job, very, very difficult job. So learning the job, it doesn't happen overnight. It doesn't even happen in 6 weeks. It's a couple years until a caseworker is really comfortable in the field, and so there's constant turnover, those challenges there. But working really hard to get fully staffed, and we have I don't know how many in a training unit. So positions filled, but caseworkers aren't fully trained enough to be in the field. So working through that. And with that, I'm gonna hand it over to our in-house child welfare expert, Kelly, to talk through the system and the process.
Hi, all right, so thank you. Amy covered some of our big initiatives, but what I wanted to do, and I have some information for you guys, just about child welfare process. And as Amy mentioned, one of the things that we've been doing in the last couple of years, I've been going out to community partners and trying to educate, and because I think that there's some misunderstandings about child welfare process, the laws, the regulations that guide the work. So I wanted, and I know we don't have a ton of time, and trust me, I can talk about child welfare all day, but I'm gonna respect everybody's time, but I wanted to give you guys an overview of what work is like for a child welfare worker. And in that, I also wanted to talk about some changes, because as you all know, our work is very much governed by the Office of Children and Family Services in the state, right? So when they initiate change, we have to incorporate that into our practice here at the district. What you have in front of you is it's a basic slide presentation that talks about child welfare process, mandated reporting, some of the assessments that child welfare workers do, the process of what happens when a report comes in, and the steps child welfare workers need to take. And then also I just gave you a little information on mandated reporting, because again, as I mentioned, OCFS has done some changes, has made some changes to mandated reporting, and I wanted to kind of highlight that. Then I also attached an administrative directive from OCFS, which really has been a major change in our work as it changed in January 1st of 2022. OCFS changed the standard of evidence that's required for us to indicate a report, or when a call comes into the hotline. So that's a really huge change in our practice. And then lastly, OCFS has a practice manual for child protective work. And the last thing in your packet is a summary of the regulatory responsibilities of a child welfare worker when addressing a report that's made to the SCR. So I'm not going to go through all of it, but I just thought it would be good resource information for you guys, okay? So I want to start with when the majority of our work in child welfare is when calls come into the state central register, the hotline, child abuse hotline. That is the majority of where we become involved with families. We do have voluntary preventive services where people ask for services, and some of our cases come through that avenue, but the majority of our work really comes through the hotline, right? And one of the things that I like to make clear to folks is making a call to the hotline is not an immediate response. And I think the community sometimes doesn't understand that. For years, Onondaga County, as well as Monroe County and Rochester, had our own hotline in-house, but OCFS changed that years ago, and no longer can any local district have their own hotline. It all has to be streamed through Albany. So when calls come into the SCR, they actually go to Albany. And there's about an hour and a half lag between when they accept or get the report to when it gets to us. So I always like to emphasize that a call to the hotline is not an immediate response. Okay, so that first slide really steps you through what happens. So when a call comes in to the hotline, the SCR in Albany, they have a team of people who determine whether or not the call should be registered, because often reports aren't registered. So what happens in Albany is they ask a bunch of questions to determine lots of things. For example, is the adult in question, is that person really truly a person legally responsible as defined through the law, right? So sometimes calls come in to the hotline, to the SCR in Albany, and they're not registered because the adult that is being described doesn't fall under that category. So the SCR would then make a law enforcement referral or just say there's not enough to register it. So once it is registered, like I said, hour and a half, it gets to us. And then, we start our CPS process, which is that last handout that I gave you, all the steps that child welfare workers need to take during the course of an investigation. The other thing that has happened in the last couple of years is OCFS has changed some of the training related to mandated reporters. Those of us who are mandated reporters are required to take a training every so often to, and all mandated reporters in the community have to take it. And there has been a little bit of a shift in the content of that training, and the mantra really of OCFS, again, our guiding oversight agency, is support before you report. I think that is born out of a lot of disparity in the system, and when looking at, you know, the number of reports that come in, whether they be indicated or unfounded, which I'll talk about, there's a disparity in the system that poverty shouldn't automatically constitute maltreatment or abuse, right? So the whole mantra of mandated reporting now is support before you report. What is it? And I'll give you a real quick example. Educational neglect, right? Kids being absent from school. The SCR, the hotline, won't accept those, they won't register those calls unless schools can really articulate the steps that they have taken to remediate the problem. You know, have they had meetings with mom? Have they sent letters? Have they tried to set up services? Have they done all these things before they'll even accept it, register it? So there's been changes to that training, which really guides a mandated reporter's, you know, work and responsibility. The other thing I wanted to mention is Governor Hochul just signed the Anti-Harassment and Reporting Act. For years and years and years, folks could call the hotline and not leave a name or any contact information, which really has been a barrier for doing investigative work, right? Because when it's an anonymous call, the CPS investigator doesn't have anybody to call to gather information. So this act will go into practice sometime this summer, which will no longer allow anonymous reports, with some exceptions like children. They're working out all the details of it, but this is a huge win in our opinion, because one of the first things an investigator does in their course of work is call the source of the report to kind of confirm if the allegations, if they were written down right, like what was received at the SCR. So this will help child protective work. And again, midsummer that should come out, okay? And then I want to just talk about.
Kelly, do you mind people ask questions in between?
Oh yeah,
Or do you want us to
sorry.
wait until
No, you
it's
can
up to
ask questions. Go for it.
Okay. With that point, I was looking into it this morning. The person will still remain, not everything about that is
Always
Yes.
has been.
clear. Yeah, that's not gonna.
Yep, it always
Just make
has
that clear.
been and always will be. And not divulging the source of the report is something that's really ingrained in child welfare workers' brains upon inception.
Yeah.
Like, yep, so it'll still, we don't give out the source of the report. Other questions before I? Okay, yeah, sorry. All right, so just thinking about child welfare or child protective process, you know, like I mentioned, the majority of our interactions with families come through the SCR. New York State is what's called a dual track system for child protective work. And it's surprising to me that not everybody knows that, because we have been a dual track system since the legislation was passed in 2007, and the first pilot of that dual track was in 2008, so it's been around for a while. That alternative track is called FAR, Family Assessment Response. It's an alternative approach to child protective work. And Onondaga County has been a FAR county since the inception of FAR. And basically, when we think about child protective work, we automatically go to that investigation, right? Like, so a report comes in, and at the end of it, there's either these allegations are true, so it's indicated, or they're not true, so it's unfounded. With FAR, there's no indication or unfounding at the end of it. The whole premise between family assessment response is really about, it's very family-led. Like in an investigation, an investigator might get the report and based on the allegations, go out to school to meet with the kid and not tell the parents that they're meeting with the kid. In the FAR approach, it's let me call mom and dad and say, hey, mom and dad, somebody has concerns about Johnny. I'd like to schedule a time to come and meet with you. And who would you like to have at that meeting? Like, who are your resources? Who are your supports? It's very family-led. Okay, and again, there's not an indication or an unfounding at the end of it, right? So that slide that's in front of you with child welfare process is just kind of all the avenues that a case can take, whether it be FAR or a regular investigation. So call comes into the SCR. The SCR passes it on to a local district. Local districts have the ability to determine what allegations they want to screen to FAR. There's a couple legislative knockouts, sexual abuse, any severe physical abuse legislatively can't be tracked to FAR, but every other allegation, counties have the ability to determine whether or not they want to track it to FAR. So call comes in, gets to the county, we decide if it's going to be FAR or investigations, and then the worker assigned to it goes through and does all those steps that's in that. Go ahead.
So, sorry,
No,
with
it's okay.
that, does the caller have to, I'm trying to think, if somebody wants to call, they say, hey, I'm just worried about this person, right? Is it a different report way that the caller is going to report it?
No.
Or is it just, I have this basic report, so the caller isn't saying, hey, look, I'm concerned about this kid, or, you know, I have concerns about the situation this kid's in?
Right, so the call to the actual SCR is going to be the same, whether it gets tracked as an investigation or a FAR case. What happens at the state in Albany at the SCR, they will code it as FAR eligible if it's an allegation that legislatively can be FAR. So it's not severe physical abuse, it's not sex abuse, because they legislatively can't be screened to FAR. So then it gets dispatched to a local district, to us. And then as a district, because we're obviously not the only FAR district in the state, we can make our own internal decision about what allegations we want to screen to FAR. So historically in Onondaga County, we have screened educational neglect cases to FAR, or pre-marijuana being legal, those cases would be screened to FAR, or maybe allegations around living conditions of the home, right?
And,
Oh, go
sorry.
ahead. No, it's okay.
And if that call comes in, let's say you bring it up as a case, as if there was something like, and whoever is there realizes this family just needs help, are they taking care of that, or is it being sent to somebody that would be covered under FAR? How does the staffing of who covers FAR and who covers the cases?
Yep, so,
No.
so it's the same group of workers, right? And whether they're an investigator or a FAR worker or even an ongoing services worker, part of our role is to attach families, connect families with services. So that would happen. So again, back to this flow chart kind of handout, even in situations that are run as a regular investigation that are unfounded, right? That doesn't mean we're saying, oh, it's unfounded, we're done with you. We're forever offering services. One of the things that happened again, I keep mentioning OCFS has changed regulation. On January 1st of 2002, and that's that administrative directive memo that I gave you guys. The standard of evidence required to substantiate or indicate a report changed. For years and years and years, it was some credible evidence. And as of January 1, 2022, it changed to a fair preponderance of evidence, which is a much higher standard to be able to indicate a report. You know, in very simple terms, some credible evidence used to be, okay, in my investigation of all the information I collect, some of it has to lead me to these allegations are true. That was the standard for many, many, many years. With a fair preponderance of the evidence, it's of all the evidence that I collect in the course of my investigation, more of it has to say these allegations are true than the information that says they're not true, which has really increase the difficulty of indicating report. So, and it's interesting, previously to the change in the standard of evidence, 75% of calls statewide made to the SCR, to the hotline, were unfounded. And that was when the standard of evidence was some credible evidence. Now, with a fair preponderance of evidence, and the state hasn't really given us data about that yet, but I'm imagining the percentage of unfounded reports is going to be much higher, right? Because it's a much higher standard to be able to say, yes, this report is indicated. And like I was mentioning before, indicated or unfounded, we're still, if the worker, whether it's a FAR worker, an investigator, or services worker, if we assess that a family needs support and assistance and resources, we're forever hooking families up with services. You know, it might be a situation where we don't have a fair preponderance of evidence to say these allegations are true, but we can say, yes, this family needs, you know, Johnny needs counseling, or mom needs, you know, an in-home service. We can still set that up. We have a very rich preventive, voluntary preventive arm of our agency, of our division. So we're hooking folks up with services all the time. So then, like, if we take it past the indication, that's when we have the ability to seek court intervention, right? And that's when we look at, based on the circumstances, and obviously we need to weigh, you know, consult with our legal staff. Do we have enough to file a neglect petition or an abuse petition? And if we go to court, then we're asking for court-ordered services sometimes with those indicated cases. The other thing I want to mention is some misunderstandings about our legal authorization or our legal authority to remove children. Because what I've learned, as Amy's mentioned, I've done my road show all over the county trying to educate folks about child welfare work. There's some misunderstandings about how easy it is for us to remove children. And first of all, the philosophies of this work is really that children do better with their families. The regulation and law really guides us to, we need to do whatever we can to leave children in their homes, right? But in the event that we can't, which is really in our work, it's a really an assessment of danger. If there's danger and there's nothing we can do to protect a child or children from danger, and we have to look at a removal, it needs to be the intervention of last resort. And there are times that we go to court and ask for removal and judges tell us no, right? That's the reality of our work. We go in, we present our case, this is the information we've gathered, and a family court judge does not uphold that removal. You know, so that we cannot remove children without getting approval from the court. If family court is open and operating, we can't remove children without going to court first. After hours, when family court isn't in session, we can do what's called an emergency removal. There's part in the statute and the regulations that allows us to do that, but we have to immediately go to court after to have a judge uphold that removal. All right. Law enforcement, and this is another misunderstanding, law enforcement really has more legal authority to do a removal than Child Protective Services does. Because law enforcement can do a removal at any time. They can walk into a situation and think there's danger, and they can take protective custody of kiddos. We can't do that in a business day if family court is open. We have to go to court first and ask a judge to grant us a removal. All right, so folks, I think, sometimes think we have more legal authorization to do that. And again, the foundation, the belief system of child protective or child welfare work in this state and this country, really, is that kids do better at home with their families, and that we need to be able to show everything we've done to keep a family intact before we're asking for removal. Okay, questions about that? I get going.
Not necessarily that, but we obviously touched on the demanding nature of the work and what that can mean for our employees. One of the things that we've discussed over the years is mental health resources for first responders, for example. What resources do we have available for caseworkers to help them with the things that they experience on a day-to-day basis?
Yep, we have a licensed mental health counselor that runs groups and meets individually with all of our workers. It's just reach out to Kate and you can meet with her. She has a group. We have, she also has open office hours where she just kind of spends time, a couple of hours, a couple of weeks, a month, where workers can just kind of go up if they feel that they need to, kind of dump, so to speak, right? And we also have Genevieve, who also is another registered or a licensed counselor that meets with our workers as well. And then we also, the county has the EAP and all of that, and we make referrals. Yeah. Other questions? All right, so the last few slides, the assessments in child welfare, that slide really talks about child welfare workers have to do, regardless of being a FAR worker, an investigator, or services worker, or voluntary services worker, those 4 assessments need to be done at every contact. They're gathering information to make decisions about those assessments, right? So in really simple terms, when we're talking about the assessment of abuse or maltreatment, otherwise known as neglect, that's really taking the information we've collected and weighing it against the legal definition of either abuse or maltreatment. And one thing I'd like to mention about maltreatment, a big part of the maltreatment legislation, both in social services law and the Family Court Act, is really about this concept called minimal degree of care, which is, all my workers would say it's like a 4-letter word. No one likes minimal degree of care because the reality is the standard of care that a child can receive in this state, or the country for that matter, is very low. Like, parents need to do very little for the law to say that they are meeting basic needs. Just to give you a simple example, one basic need a parent or caretaker needs to provide is nutrition, right? Got to feed your kid, right? So many of us would think, okay, that's 3 meals a day and a snack and, fruits and vegetables and all of that. It's really not. The minimal degree of care standard is children need to be given enough food and liquid to grow, right? So think about that. Like, kids, as we know, schools do a fantastic job of feeding kids all day long. So, kids being provided meals at school and parents not having food at home is still meeting the minimal degree of care standard, which I don't like it. None of my workers like it. But that's the law, right? So minimal degree of care is very minimal. Questions about that? That's usually a hot button topic. Okay. And then lastly, the 2 other assessments that workers do is safety and risk. And I put that slide about danger because in child welfare work, the assessment of safety is really about the assessment of the presence of danger, either immediate right now happening or imminent, about the foreseeable consequence. And it's the assessment of safety. And if that assessment is danger, that's only when removal comes into play. And that's only if there's nothing that can be put in place to protect the child from that danger. So it's really the assessment of danger or of safety that is what potentially results in a removal. Okay? And then risk, just by definition, there's a slide on that, is the likelihood of future abuse or maltreatment. And so for a child welfare worker, they are constantly collecting information to weigh against those 4 assessments at every contact, whether that's sitting in the living room with a family or on the phone with a teacher or talking to a doctor or interviewing a kid. It's all of that information that guides their assessment, which really dictates our course of action. Okay?
Especially with the higher bar of evidence being in place, is there any degree of, is there a cumulative nature when repeated calls come in, or are we kind of starting from a clean slate every time?
No, or, well, yes and no, I guess is what I'll say to you. Okay, so unfounded reports still are in our system, we can see them, right? So part of investigative practice is looking at history, the review of history. So that does come into play. And I think, this is kind of a sidetrack, I think with the Anti-Harassment and Reporting Act, that might help some of that, because we often get, you know, like exes and they're hotlining each other, right? So there might be a bunch of reports, so it looks like the history is such, but it's really not when you dig deeper.
Right.
But a review of history is always looked at. And we also internally have what's called a flagged case protocol, and repeated reports or, you know, different circumstances, medical stuff. Those cases require a level of review by an administrator, you know.
With that, the no longer having anonymous reports, do you have any idea what kind of impact that'll have on your call volume? Your case volume or whatever? I know that you expected to have some sort of.
About 10% of the reports in the past have been anonymous. So depending on how many of that 10% will provide a name and how many were, you know, the harassing kind of reports, about 10%.
I do think always having a name for the source is going to help investigators be able to have a more effective investigation. Yeah. So lastly, what I put on that last slide is just some key things that always have to occur in every investigation. So regulation and law says that we have to initiate an investigation within 24 hours. And in that, we have to do what's called a 24-hour safety assessment, you know, a decision about child safety. And what the regulation doesn't say is that assessment of safety doesn't automatically have to equate to having interviewed a kid within 24 hours, because there's all kinds of ways we can collect information to guide our safety assessment, right? We also have to contact the source of the report, review of history like you asked. We also have to make certain in every investigation that we're talking to collaterals, whether it's medical providers, school, therapists, like just, you know, could be, you know, like other family members. We have to get information from a variety of sources to inform our decisions. Again, we talked about the assessments. And technically, investigations need to be closed within 60 days. There are some times when that's not possible. Like, for example, we have a team, as I think you probably all know, of caseworkers who work at the Child Advocacy Center and work on abuse cases, and sometimes that collaboration on the multidisciplinary team with law enforcement and the ongoing simultaneous criminal investigation doesn't allow for us. We have to keep it open because we're waiting on information from them. We don't want to step on their investigation, but technically they need to be closed within 60 days.
And with that first bullet, essentially there's a level of triage where we're able to determine the urgency of any given report, correct?
Yeah, so like based on the allegations of the report, that's going to determine what steps we need to take immediately, right? Like, so for example, if the allegations allege that there's a child with marks and bruises, we're going to go out on that immediately. We want to see that kid. We want to try to see that kid before he goes home from school, right? But it just kind of depends. If it's a messy house, you know, we might, you know, have a little more time, right? Yeah. So that's really a really brief overview of child protective work. The other thing I want to mention, Amy, mentioned it a little bit. The school-based team was Syracuse City School District. That, like Amy mentioned, we've seen a decrease in the number of reports from last school year to this school year in this particular time frame, right? So I think the collaboration has increased significantly, and our hope is to bring that model to the remaining school districts in the county.
And how many cases do you get a year? Calls?
About, in 2025, we have a little over 5,000 initial
Yeah.
calls. Sometimes there's
Yeah.
repeat,
Subsequent.
You know, how many cases caseworkers kind of manage at one time?
It varies
Yeah.
depending on, there are some high traffic or high volume times of the year. It's usually around October when all those ed neglects, because what happens is schools have, their own attendance policy, right? So their school policy might be when a child reaches X number of absences, we need to automatically call it in. And even, now with the change, they have to make sure they've tried some stuff. So we get an influx in like mid-October, end October. And then when we get to March, when we're getting closer to the end of the school year, we get an influx there. So it might vary based on the time of the year. And the other thing, Amy mentioned this, we have, our workforce is pretty new, right? So everybody works at a different pace, right?
When you have a case and there's a need for referral or connection with services, how is that process happening?
So we have a preventive unit that coordinates that. So if I'm an investigator and I'm working on a case and I realize that the family I'm working with needs services, internally we make that referral to the PPS unit and set up. Or, like I mentioned before, we are very preventive service rich in this county. So we have access, which is a point of resource. Both we can refer families to access, and access can really kind of assess what the best service will be for the family. So that's
So it's a secondary
Yep.
process.
Yep.
Let's follow up, like with, outreach from CPS to, like caseworker, or not caseworker, but these services.
like when the case is open, or after, like if it's a situation. Okay, so when the case is open, those service providers are collaterals, and that's part of a CPS investigatory process, is to talk to collaterals, right? If it's an ongoing open for services, like court orders are in place and we're working, that caseworker is regularly communicating with the services involved in that family, because it's part of the family service plan and looking at trying to figure out the progress the family has made towards the service plan. If it's a situation where, remember how I was mentioning maybe we don't indicate it, but the family needs services, so we set up voluntary services. Our PPS unit has case manager oversight of those cases. It's not as intense of an oversight as a caseworker being the case manager, but they're having ongoing contact with the service that their families are working with.
Is there a standard for how often they have to connect with them? No.
Any other questions from committee members? Do Charles?
I do have a question, and it might have been stated already. How many vacancies do you have?
We have 15 caseworkers.
And can you touch a little bit on that minimum 15, because, we do get calls sometimes, and that help us navigate. Might be call that says, we need to call child protective the house. Does the children need a bed? Can they sleep on the floor?
Yep. Minimal degree of care is one of the hardest concepts for certainly public, but certainly for child welfare workers to digest, right? Because like I mentioned, it's very minimal. So minimal degree of care, and that language is really in the maltreatment law legislation, right? And the law really doesn't clearly define it. And it doesn't clearly define it on purpose, right? Because what works for Amy's family might look different than my family, right? So the law is written in a way that it can be individualized to people, right? And it also has to be weighed against the other language in the law, which is about something a parent does or doesn't do, acts of commission or omission, right? And harm, right? And that, and I know I'm simplifying it, you know, there's way more legal words in the law, but it's an and statement, it's not an or statement. You have to have something a parent did or didn't do and harm, right? So, messy house, right? If there's a messy house, because we go out and we've seen very deplorable conditions, you know, maybe there's animal feces on the floor, right? But when we're looking at the harm point, if there's teenagers in the house, that looks a little different than if there's a toddler toddling around, right? So it's really not very concretely defined in the law, right? It's just you have to have that and statement, something a parent did or didn't do, and the negative impact. It's tricky. And the other thing, and we didn't mention this, but in 2018, prior to 2018, OCFS, again, our oversight agency, had regional child welfare training. So that meant, you know, there was New York City, Albany, Syracuse, Rochester, and Buffalo, where new workers could go and have in-person training. In 2018, they built a training center in Rensselaer, New York, the Albany region, and determined that all training needed, in-person training needed to be there, right? Which really impacted, it's a 6-week training. So if you think about having to be away from, if you live in Buffalo, if you live out here, right? So they moved to online training. COVID had something to do with that too. Online training, which is very different quality of training online than in person. So with a concept like minimal degree of care, you know, the training isn't as effective as it used to be. So we do a lot of in-house training to help strengthen the training that they get online, because you know, when a potential hire says to you, I want to take this job, but I can't be in Albany for 6 weeks, we're certainly going to allow them to take the online training, but we're going to need to supplement it. And we do.
It's not a direct comparison, but I see a lot of parallels in special education. We use the term least restrictive environment,
Yes, yep.
where you're
Yep.
trying to minimize the degree of
Yes.
intervention from
Yep.
the state, because
Exactly.
idea being kids are going to excel being in their environment with
Yep.
their family. And obviously there are situations where unfortunately
Yep.
that's not the
Yeah,
case,
yep.
but it needs to be the kind of the default position.
Yeah, it's a great analogy.
Charles, we're a little over. Do you mind if I move on? Be quick.
Go right ahead.
All right. So thank you both. We
Thank you
also
for
have to
having
hear from the health department.
Yeah, sorry.
But no, you're good. It was only a couple minutes. We're doing actually good in time. I just don't want to bump into our
Like I
next
said,
meeting.
Yeah.
Thank you both for coming. Really appreciate it.
Thanks for
And
having us.
hopefully we'll.
Could you complete the sign-in sheet for the
Sure.
Thank you.
of business is the health department. We have an item that we will have to vote on, and then we will get a presentation overview of the health department as well. Dr. Anderson.
Sure.
Welcome. Don't know if everybody knows, Dr. Anderson from the health department.
Hi, nice to see you. Thank you for having me. So the first item, the local law. Some of you may remember that going into the 2026 budget, let me back up. So as part of our activities, particularly in environmental health, and we have our Director of Environmental Health, Jeff Till, here today, and Steve Smorrell, our fiscal ops support guy, who can help answer some of these questions. But there are a lot of activities that go into inspections, enforcement, and there are fees that are set, at least in terms of the maximum fine, by New York State Department of Health. So going into 2026, we had updated fees related to weights and measures, I believe was the one, because we go out and we check scales and things like that. In updating, those were approved. In updating those fees, there were errors that entered into the schedule related to some of other standing fees that had not changed. So we're seeking to put those fees back to where they were previously. Did I get that okay, Jeff?
That's exactly right.
Okay. And there's a summary of the fees here. You can see the wide variety of things we do, particularly in environmental health, and then there are specific fees that are listed where the errors came in.
So we're just setting these back to where we wanted them, right? Should be, is it budget neutral?
Correct. Every year they tend to update their fees, or New York State does. An old copy got pulled into some of those fees, so it was just, an error in terms of that came through with the county budget process.
Thank you for that. That was my question, because I thought that this was during the budget process as well.
Yeah.
So it was pointed out to me that the school water sampling was not on the last schedule. Is there, the one that was approved in like October?
So not all of them make everyone, because they have so many different ones, so we truncate each one sometimes. So I believe Jeff can speak specifically to that. It may not have been on that specific schedule.
I'm not sure where that omission came from. It has historically been, I think, $120. And this is what's seeking to secure that money.
Okay, just for the people at home, that number hasn't changed. It just is carried over. The 120 is consistent. Any other questions from committee members on this? Okay. Can I get a motion to move this forward?
I'll move it.
Okay. A second? All in favor? Motion moves. Thank you.
Okay. How efficient would you like me to be in this?
No, you said 4 minutes.
Okay.
Yeah. Did you jump into the next meeting? Because you're doing back-to-back.
Sure.
Back and break and all that stuff.
So I'll hand out, these are copies of our org chart. There are extras as well. And then these are copies, we have 15 copies, so there's extras to go around. But of our community health assessment, I'll get into that a little bit. That's just hot off the presses. Thank you, yeah, here. And then there's extra org charts right there as well. All right, so by way of introduction to the health department, so we do a great diversity of activities. We have about 250 employees. We do a mix of state mandated public health activities. Environmental health comes into that a lot. There are others that we are required to do as a local health entity. There are others that are grant funded programs. There are others that are homegrown programs, and we'll get into some of those. As you look at our org chart, the activities fall into 5 general buckets, I would say. So there's community health and family health, which would include things like, as you look at the bottom, our Healthy Families, which is maternal child health programming, our lead programming, special children's services, which would be early intervention and preschool, and substance use initiatives. We have, so those are kind of community outreach, community engagement, core public health. We do disease control, which means that actually in the basement of the Civic Center, we have a clinic where we do STD testing, we do TB testing and treatment, we
do family planning now as well. We also have a big environmental health program. Again, Jeff Till is here today that has a huge diversity of activities. And it ends up being a lot of the things that we end up talking about that end up in the media getting a lot of attention tend to be environmental health things, harmful algae blooms, rabies, mosquito control, food, restaurant inspections, things like that. And then finally, somewhat unique to our county, I would say, is that we have forensics directly under us as well. So we have the medical examiner's office as well as the forensics lab. So that is a little bit different, particularly the forensics laboratory. So they're doing things like firearms testing, DNA testing, rape kits, things like that, fingerprint investigations. And then finally, administrative operations like communications, workforce development, compliance. And I can go a little bit into some of our key programs, if that'd be helpful. Okay. Maybe I'll also specify when we look at the org chart. So just to orient you, so I'm Katie Anderson, I'm the commissioner. I'm a commissioner because we are a sufficiently large county that it requires an MD who has the title of commissioner. There are other county health departments that are smaller and don't require an MD, and that would be a director. We have a health advisory board that does not dictate our activities, which again is different from some counties, but they are advisory board. We have 2 deputy commissioners with these kind of banner of the activities below falling under specific commissioners, so you'll be getting to know as we go forward, Rebecca Schultz and Jessica Vinciguerra. And then we have a senior medical director, Dr. James Alexander, who oversees the clinical activities in what we call the Bureau of Disease Control, as well as advising on some of the other clinical aspects of what we do. For example, when we're out lead testing in the community, or increasingly as we start to engage clinical outreach with our substance use interventions, that would fall under Dr. Alexander. If it's all right, I'll just touch upon some of our priority public health areas, which are also ones we end up talking about a lot here. So for example, lead. We have a diversity of activities that take place in lead. We work closely in this with community development. So there are 2 different departments within the county that work closely on lead. Community development doing more in terms of HUD funding, renovating homes, supporting homeowners to eliminate lead hazards. The health department works closely with them, but we have a broader role that includes lead testing. That's something we talk a lot about. So we are mandated to and actively involved in ensuring that all children have access to a lead test, whether it's through their primary care or through us or through another community partner at ages 1 and 2. We do case management for children who are found to have elevated blood lead levels, and then we support them and their families through the process, whether they need clinical management, linkages to services to help support and remediate their homes. That's about all I was going to say about lead for today. Do you want me to pause?
Are we, what are we seeing with surveillance testing with the lead van? Are we still in the schools for the 25-26 school year?
Yeah, so that's a good question. So that's something we're going to be exploring further with the schools to figure out the most strategic path forward. So again, the requirement from New York State is that all children at age 1 and 2 should be getting tested, ideally through their pediatrician, because those are the ages where they're at highest risk of being exposed, and they're at highest risk of having the effects on their developing brains of exposure to lead. That said, we know that there are some children who fall through the cracks, and it's hard to know how many, but it may be 5 to 10% of children who don't get those lead tests. So we had done an intervention with the Syracuse City School District to go into preschools and test children to see if we could identify these children who had fallen through the cracks, to kind of test that assumption, again from New York State, that testing at 1 and 2 is the highest yield approach. And we're still parsing out what we learned from that. What we know is we found just a couple kids, which is too many, but just a couple kids who were elevated at preschool testing, and then others that we knew about. We then did, that was broad testing, so an invitation to all preschool kids to get tested, and about 50% of those families opted in for that. We also did a more targeted intervention with legislator McCarran and his district, where we worked with the schools to identify children who had fallen through the cracks and then tested them. And that may be a higher yield approach than just offering it up to all families.
Sure.
So we're still figuring out the best path forward with that.
We know which zip codes are affected. Are those zip codes primarily contained to a handful of schools, or is it a little more dispersed where it would be difficult to grasp the entirety of the issue?
Yeah. So what we know is in Onondaga County, lead is a problem throughout, as it is in counties across upstate New York. The issue is centered in Syracuse because of our preponderance of old housing and a preponderance of rental housing that may be in various states of upkeep. So it tends to be the city of Syracuse overwhelmingly that is impacted by lead poisoning in kids, and it's certain zip codes, as you referenced, particularly north, west, and south, but that's a pretty broad swath of Syracuse. So it covers a lot of the schools.
With that, are there any schools in the county that require lead testing to go to school?
Not yet.
Any other questions on lead?
One thing I will say about lead, and this also ties into substance use, which I was going to speak about next, is these are two programs where we really benefit from additional and flexible funding. So for lead, a lot of that comes directly from the county to support lead programming, which has been so helpful and important in terms of community-informed, community-responsive, tailored ways to attempt to impact the problem. In substance use, it largely is coming from opioid settlement funds. There's a couple different sources for that, but that has allowed us to be very community responsive and build out programming that we think is quite targeted. So under substance use initiatives, we are primarily involved in harm reduction approaches. So we have a strong and growing peer support program where there are individuals who have lived experience, who are engaging with members of the community who use drugs, meeting them where they're at and helping them along their path, whether it's treatment or needing someone to kind of talk things through with, linkages to fentanyl testing strips, xylazine testing strips, to kind of mitigate risks, syringe exchange programs. And we think, in part due to this and the other programming that's taking place in our county, we've seen a dramatic drop-off in overdose-related deaths related to opioids in the last couple of years. A huge drop. I think it was 40% from 2023 to 2024, and that decrease was sustained in 2025, it appears as well. And we think that that's because of these harm reduction approaches, and in particular, flooding our community with Narcan. So when Narcan first came out, it was really hard to get, it was expensive, you'd need a prescription, and now between the county, other partners like Helio, ACR, it's thousands or tens of thousands of doses of Narcan that are out and saving people's lives.
Questions?
All right. The other programming that I'll touch on under community health as a big priority going into 2026 is Healthy Families, which is maternal child health programming, and we have several programs that fall under that. So we're fortunate to have WIC, or Women, Infants, and Children, under the health department. We're one of the few counties in the state that consistently exceeds our targets. So the last couple of years, we've been at 106 to 108% of our target population served for WIC, which is a testament to the amount of need in our community, but also a testament to the excellence of their outreach. So that's nutritional supports for pregnant women and their children. We have a couple home visiting programs. One is called PITCH, which is a state-funded program, and I can't recall all the details of the acronym right now, but it involves community health workers, social workers going into homes to support families. We're one of the few counties that has Syracuse Healthy Start, which is primarily focused on select high-risk zip codes in terms of maternal and child outcomes. That is HRSA funded, so that's federally funded. And these programs are really driven by, and in 2026, this remains one of our big priorities, the persistent disparities that we see in terms of health outcomes for women of color and their infants in our community, with maternal mortality and infant mortality being several-fold higher for their infants and for those moms. So it is a really important problem that we still have yet to see major strides in. And I'll also mention under Healthy Families, we have a homegrown refugee and immigrant health hub program. which is in collaboration with Upstate, and this has become a resource for our whole department, where individuals who are either coming into the United States and into our community are triaged and screened in terms of their health needs. And now with fewer new Americans coming into our community, it also just serves as an informational and resource hub across our programs for making sure that people get culturally informed care.
Questions?
You mentioned one of the programs is federally funded. Are you seeing an impact with what's happening at the federal government with any of the other programs?
Not yet. There's been a few areas where there's been some concern. One was, I don't know if this is on here, but our emergency preparedness, that grant continually gets flagged as potentially being at risk, but it has not yet been impacted. We have been involved in a public health fellows program, which was funds that came through the CDC and then through the state to us. That has been on again, off again, but remains on again. So there's been some concern and some chaos, I'd say, in terms of what's going to be going forward, but so far our funding is intact. WIC is also federally funded, of course, and that has not yet been significantly impacted, but it would be a significant impact to our community if it were.
With that, when do we get those federal dollars? Like if something happened in 2026, does that kind of filter down to the county really quickly, or would that take a couple years to get to us?
It depends.
Okay.
So we have, if you look at our budget, about half of it is special children's services, early intervention, and pre-K. So that's a unique aspect of our budget, an important aspect of our budget. But so if we looked outside of that 50% is grant funded. Of that, about 10% is federal, 40% is state. The state is large, a lot of it is passed through from the federal government, so some of that may take a little bit of time. And again, none of them have been impacted yet.
So there are also grant agreements for each one of these, so typically they get non-renewed as part of the grant agreement, and we get notice ahead of time about the end date. So any costs that are initially set out would still be reimbursed for those. So our grant dollars, and they're scheduled, most federal awards start October 1st of each year through September, so. Yep.
Anything else for this? Charles, when she's done, we'll come to legislators that are on the outside. Sorry. Just because.
And I may leave some of that at that higher level then. You again will be learning a lot about environmental health, which is a very diverse, very active, and large division. Particularly in the summertime, you'll be hearing about the activities of environmental health. Disease control, again, I touched a bit upon our clinical activities. This is under the leadership of Donna White. One thing I will mention within disease control is that there are increasing gaps in access in our community to primary care, and we're not unique in that. That's a national problem. But we increasingly see the needs and the gaps in our clinic. So for example, immunization, we are responsible for making sure that children have all the vaccines that they need to be able to go to school in the fall. In the last couple of years, our volume of children seen has tripled, and that's in part because of not enough primary care appointments. So increasing need in volume within all of these services. I'll leave it there in terms of the overview. Next, I'll talk about the community health assessment, which you all have copies of that. So this is a New York State requirement, but I think we excel in putting this together. We have very strong epidemiologists and data teams. So what the community health assessment involves is two aspects. So one is receiving our data either from New York State Department of Health or from local sources and summarizing the state of our community's health. And that's across both health outcomes as well as social determinants of health. So this is very, very, very handy. I'd encourage you all to spend some time with this in terms of, it lays out social determinants of health, so poverty by geographic area, by race, ethnicity, other barriers to maximal health like food insecurity, access to transportation, housing insecurity, things like that, and then goes into various health outcomes. And it's very, I'd say, eye-opening. One thing that comes through as a consistent thread through our community health assessment Unfortunately, and which is a call to action for us, is disparities that start at the time you're a fetus along racial and ethnic lines, as well as geographic lines, and then continue until the time that many individuals in our community are experiencing premature death, which is death before the age of 65, which again goes along geographic and racial ethnic lines in our community. And then finally, it ends with summaries and subjective perceptions from our community of what do you see as your priorities, what are your primary concerns. And to do that, the health department goes out and engages with, I believe this year it was maybe 2,000 individuals that complete our survey and weigh in on what they're most concerned about and what they're most worried about. So there's a lot of really important and interesting data in there that also helps us set our priorities. And that includes data on lead, substance use, maternal child health outcomes, nutrition, other priorities.
Is there a hard copy of the CHIP as well?
There can be. Community
Yeah,
health improvement
community
plan.
health
Yep.
improvement, thank you. Yeah, if you can just get some of the legislation
Sure.
sent over.
Yep, and I'll mention what the CHIP is. So we talk about the CHA, the Community Health Assessment, and the CHIP, which is in some counties done separately between the county health department and local hospitals. In our case, we work very closely with our local hospitals, Crouse, St. Joe's, and Upstate. And it is a collaborative process where we identify what are our priorities for the next 3 years and how are we all gonna together and individually tackle these problems. So it's a long discussion of what are the possible priorities we could put in. They settle on 3, and for this CHIP, it is nutrition, chronic disease, and maternal child health.
Sorry, what does CHIP stand for?
Community Health Improvement Plan. Yep, and that's available on the website as well, but we'll get some hard copies as well.
I'll give them a second. And then in here, I saw talking about obesity. I didn't see how it measures obesity. Is it like BMI thing, or is it fat number of?
I would guess BMI.
That's right.
Yeah, I would think so. And that again is geographically different. Different school districts have different obesity rates in our community.
I just didn't know if BMI was a value measure of that. Right, 'cause
I can get the information on how they measured that. Let me go back to you.
In terms of the sampling, do we have demographics in terms of making sure that we're collecting enough data from specific groups to have a representative source?
Yeah, that's a great question. So there are earnest efforts made to capture a diversity of perspectives, including administering the survey in different languages, trying to go to different parts of the city and engage people. It tends to be a little bit biased, as you would guess,
Yeah.
towards more of a white, possibly a slightly higher income respondent pool. But each year, or each time they do this, they get better and better. I can't recall exactly what the breakdown was. There are a diversity of voices captured, but it is a little bit skewed.
Yeah, and I'm happy to see, even looking at this, that I didn't realize it was offered via hard copy as well. So that kind of erases some level of bias just in terms of, technological literacy, for
Yeah.
example.
When you kind of going along those lines too, when you're distributing the survey, do you like work with different partners like the libraries or to get it more out into the community, or like kind of, do you know, the reach out?
Yeah, there are significant collaborations
Yeah.
that go into it. I can't list them all at the top of my head. But yeah, there are vast partnerships that go into trying to distribute the survey widely.
I think the partnerships are clear looking through the CHIP as well. And that kind of leads into one of the things I wanted to ask, but what progress have we seen in terms of the academic health department that we established? And how are we implementing that to improve access to care and health outcomes, et cetera?
Yeah. So for context, we are really excited that in 2025, we received legislative approval to enter into an intermunicipal agreement with SUNY Upstate as a county health department working closely with Upstate. And that follows a nationwide model called an academic health department model, where local health departments, either county or state, are working closely with an academic learning center. And the idea is that you are efficiently leveraging resources, able to collaborate efficiently, and pivot to tackle emerging public health priorities. So the Refugee Immigrant Health Hub, for example, would be an early example of how we can efficiently work together to try to address problems. In terms of setting our priorities, some of that will be evolving, I would say. There's already, if we look at SU and Upstate, there's already dozens of touch points that are already kind of aiming to tackle some of these issues. The goal of the academic health department is that it gives a type of overarching structure to that, where things can move in a bit more strategic sense. So there'll be a steering committee, for example, that'll meet at least a couple times a year and kind of review what we're doing, how could we do it more efficiently, what are opportunities that we could exploit further. So it'll certainly play into supporting the CHIP and build upon what we have and just kind of put the scaffolding around it.
One of the other things that I saw is it mentioned some of, I'll give you an example, economic stability, right? What are some of those determinants of how do you engage those as a department, or you just like bring awareness to them? How does that relationship of you recognizing it as a problem and us being able to address it?
That is a really good, complicated question. Yeah, it's a good one. So I would say in a couple ways. So one would be when we recognize that there are differences in how people can achieve their best health and barriers to that by economic, demographic, geographic lines. It's critical that we first understand that and acknowledge it, and that we have the right people in place then. I'd say that's step 2 to help us engage with that community. So that's where this discussion of trusted messengers and people who reflect the community that they're coming from and who may be able to better pass along those messages or engage people is important. So having the right representation. And then the loftier goal, which is even a little bit farther down the road, but really important, would be engaging those people, and so we can kind of build up communities and provide workforce development and career pathways for individuals who are from all communities. Yep.
Anything else from committee members? Charles, sorry.
No, it's quite all right. Appreciate it. Just asking might just be a threat, not actually having Trump. Just threatened to cut $85 million in health funding in your state. Will that impact anything if it happens?
Are you talking about the federal Montana money? So most of that money isn't within the health department budget. It certainly will be a huge impact. Right now, obviously, there's been, it has been overruled for the time being. We're closely monitoring that, but it would have significant impacts on the county in terms of that. We're continuing to watch that, monitor it. There's awfully for the majority of it. One big one is obviously childcare. It's just something, would be a significant impact for daycare providers, ourselves, and something, that the county could fill that gap as a state and federal program. But we're continuing hopeful that will continue down the path and that will be impacted the whole, obviously, provide.
I was looking at the health assessments. This is great. The opioids and other things. It didn't seem, is there anything in there about the suicide rates? I'm just asking.
Yeah, that was in there somewhere.
Yeah. And what would you say the rates are?
For suicide rates, I don't have those at the tip of my head, Legislator Garland, but I can get back to you about that as well.
Yes. Chairwoman.
In regards to the response to some of these communications.
That would be nice. I know it's inconvenient. We gotta figure, yeah.
Charles.
I figured I could ask you.
I've been trying to get everybody else. So, in response
to some of the statistics that are in here in the Hello? Okay. So one of the statistics I was looking in there was just the pre-65 deaths and the incredible racial discrepancy that is there. What strategies does the health department take to mitigate things of that nature when we come across these statistics to take responsibility as a county to change that?
So that's a good question, and I think two thoughts about that. One is, again, these threads of disparity begin at the earliest stages of life and then continue and probably worsen as you go through your life. That informs, for example, for our community health improvement plan, the priorities of maternal child health, where there are unacceptable disparities. Nutrition, I think, plays a big role in that, access to nutrition and access to care. So that informs a lot of what we do. So when we talk about our strategic plan, equity is a key component of that and trying to eliminate disparities across the lifespan. And it cuts across all of our programs and almost all of our health indicators.
And who participates in developing that strategy? Is that
The community health improvement plan?
Yes, the community health
So
improvement
it
plan.
is largely the county working together with our hospital partners, but there's other community input into that as well, but largely across St. Joe's upstate.
Okay, excellent. All right, thank you.
Anything else from the committee? We have time for one question, somebody else. No? All right, well, thank you, Dr. Anderson, we appreciate your time. And the last item on our agenda is an informational from Chairwoman Watts on board appointments.
Yes, everyone. So I wanted to just take a brief moment to review how we are going to do board and committee appointments and confirmations moving forward. So they've been done a number of ways over the years. However, the reason why the legislature plays a role in these appointments is to create connection, right, between our constituents, us representing our constituents, as well as making sure that the legislature is aware of all these important issues that are represented by these different boards and committees. And there are two major pathways that we participate. One is through appointments, which are typically assigned to the chair to make those appointments. And then there are the confirmations that the county executive sends to us and require a vote of the legislature. So we have been working on going through all of those boards and commissions. Shout out to our new legislative staff that have been doing lots of reading through minutes and homework to check those records. Some of that is still underway, but we have matched each of the boards and committees that we are responsible to either confirm or appoint to a committee. And so there are some that have been appointed or connected here to the Health and Human Services. And of course, my computer decided right now would be a good time to update. So I will, yes, but I also have a list here in terms of some of those boards and commissions and committees. They're called all different things that have been matched to the Health and Human Services. Health and Human Services committee here. So we've got the County Library Board of Trustees, the County Services Advisory Board, Department of Mental Health, the Onondaga County Council on Environmental Health, the Onondaga County Tobacco Asset Securitization Corporation, Syracuse Onondaga County Youth Board, County Veteran Service Advisory Board, Community Services Advisory Board, the Council on the Disabled, and Emergency Medical Services and Advisory Board. So what we are going to be asking is for the members of this committee to review the resumes. We've been collecting resumes. We will continue. We welcome any of you who have folks that you think would be good fits for this to collect those resumes, and as a committee to review the potential folks that you believe would be best suited for these committees and boards, and then put them forward to the chair, who technically then I would appoint, and we would review it in session. And so there's just more involvement at the committee level. Secondarily, we're going to be asking that those folks report back to your committee. So we're staying more connected
just brief updates from those different boards and commissions, committees, to be able to know what is going on. There is one that is currently, has 2 vacancies. That is the Onondaga County Tobacco Asset Securitization Corporation. So we've got 2 legislators whose terms have technically expired. One is still a legislator, and so if we choose Legislator McCarron, could be reappointed to that if he is interested. Colleen Gunnup no longer being a legislator, we need someone to take her spot. And so we are going to continue to be looking through all these records and getting it all refined. By next month's committee meeting, we should have a fully updated list. But in the meantime, if you have resumes, you have folks that you would like to put forward to your fellow committee members to be appointed for the ones that we are responsible for taking the lead on, would welcome that. Any questions?
Is this a comprehensive list of Health and Human Services boards? Because I don't see the Health Advisory Board anywhere.
No, I think that is on the Basecamp one that I was trying to pull up on my computer. So this is not a comprehensive list. Thank you. If you go to Basecamp, I should also highlight this for legislators. On Basecamp, there is a list of all of the different ones. This one is an information list that the staff has been working on pulling the records together. So yes, that one is also assigned to this.
And with the staying connected with the different boards in the schedule the rough draft schedule that I've drafted for the year, each of those boards will be coming and just talking to us and informing us of, things that they're working on, giving us an update.
There are also some of these, as we are going through it, some of the things that were originally in the roster are no longer active. There are ones that have been started, and so we're just trying to clean up all of those records to make sure we've got the most up-to-date lineup available. So as you see discrepancies for the next 3 weeks, that is what's happening, is us just cleaning everything up. But like I said, by next committee meeting, we should have a fully comprehensive, cleaned up list of who sits on which boards, where all the terms are, and what we need to do. Okay? Great.
Thank you.
Thank you.
Appreciate it. We are out of time, so apologize for anything else that anybody may have, but can I get a motion to adjourn the meeting? Okay, second? Second. Thank you.